Hey, what's up everyone? Welcome back to the Endo channel. To any new souls out there, my name is Brittany Denson. I'm so excited that you joined us today. Please consider subscribing to help support my channel. So today I am going to be sharing a live feed that we did yesterday over on Facebook. If you're not already following me on Facebook or Instagram, y'all come find me and say hey when you do. Okay, but yes, yesterday on Facebook, I hosted Endotruthslive Endometriosis Expert Panel Q&A. An incredible soul, Joy Roberts, put this all together. She approached me and asked if I would host this. So of course I said yes, because I mean, what advocate wouldn't want to be a part of something huge like this? I got to sit down with endometriosis experts and ask them questions that came in directly from the community. It was amazing. I am so honored to have been a part of it, and I'm so excited to do it again sometime soon. Yeah, so I want to share that with you guys, and check out my shirt, #ValidateEndo. I love it. This was given to me by Joy Roberts for the event itself, and I'm totally in love with it. She is thinking about selling me, so if you are interested, please drop some comments below and let me know, and I can get the details for you. But I absolutely love mine, guys. Before we get right into the video, still to come on the Endo channel. Things to look forward to on the Endo channel. Getting Fit with Britt will have a brand new workout for you guys, as well as my Endo Kitchen will have another Endo approved healthy recipe for you guys to try out. And don't forget, me hitting the streets here in Austin, Texas, quizzing the locals on their endometriosis knowledge. Wish me luck on that one, y'all. If you guys liked this video, please make sure to give it a thumbs up, as well as subscribe so you never miss a bit with Britt. We'll see you next time. 2 hours long of endometriosis expert knowledge. You ready? Let's go. All right, guys, good afternoon, everyone, and welcome to the highly anticipated Endo Truths question and answer. My name is Brittany Denson, a fellow Endo sister, and I will be your host. Today we have I want to give a huge welcome to our endometriosis panelists. They are taking time away from their busy schedule to be here with us, and thank you so much. Our panelists consist of Dr. DeLumba. Dr. DeLumba is an expert in treating endometriosis and pelvic pain. He enjoys proactive patient education, robotic origami, and Steelers football. Dr. Fogelson, he is experienced in all areas of gynecologic surgery and has particular expertise in management of endometriosis. Libby Hopton, she is the founder of Endometriosis research consultant at Vital Health Institute and dedicated to research-based discussion and patient advocacy. All right, last but not least, Dr. Arrington. He is a gynecologist specializing in minimally invasive surgery for endometriosis and complex pelvic surgery. So welcome, everyone. Thanks for being here.
Thanks.
Thank you.
Okay, so before we dive right in, I want to ask all of you incredible souls watching right now, share this video onto your page so we can get the word out and let everyone know that we are live now with the Endo experts. And thank you all for tuning in. Okay, so panelists, each of you will have an opportunity to answer each question. Now, we will not be keeping an eye on the time for everyone's response, so please be mindful of that during your question and response.
John, you're sharing your screen for some reason.
Yeah.
Looks like Macaulay Culkin is involved somehow.
Well, you should share it, and so I was going to.
It could have been worse. It could have been much worse.
I'm glad that all you were looking at was Macaulay Culkin, and I hope it was completely innocent.
It's Christmas. Come on. It's the time.
Oh my goodness. Okay,
Brittany,
guys.
you did say you did. Let me ask you a question. You did say we could share this, and I was like, how could we share this?
Yeah, I was looking at that too.
Yeah.
Oh, well, I'm not sure how you guys, I mean, you guys can do it for sure, but just make sure you're not sharing your screen. But on the live video on Facebook, there should be just share. I believe it's down in the left-hand corner and or on the right. Do you see it?
Is it on
That's what I clicked.
Endometriosis? Where is it? Because I can share it to my thing. Be pretty.
I'll share on an endometriosis. I see where it is, so I'll do that.
And we are banking on all of the people watching as well for them to share it on their page too, so they'll help us out. Okay, well, let's get started with discussing the mental repercussions of treatment. So I'm going to kick it off with question number 1, starting with Dr. DeLumba, and thereafter we will, let's see, who are we going to go with after that? Oh, Arrington. Arrington, you will be up next. Okay, so question 1, Stephanie asks, I just recently had my second shot of looprun. I am struggling with symptoms which began after being treated, and my OBGYN is denying that this has anything to do with my symptoms. I had no less than 2 full-blown panic attacks, 8 anxiety attacks, was convinced that I was going to die, couldn't stop crying, wish I would die so the pain and everything would stop. I can't eat, I can't sleep. Driving makes me feel like everyone else is going to crash into me. And my life feels like it's filled with a sense of doom. Today, I cannot move or control my body. My legs refuse to hold me up. My fingers require immense concentration to do what I need them to do. My brain seems to be fading in and out, and I have a temperature of 100.3. I don't know how much more of this I can take. Is there anything I can do at this time to improve these side effects I am having? Dr. DeLumba.
Well, looprun or any of the GRNH agonists certainly can have any of these symptoms that she just described. It's menopausal symptoms. And certainly the one thing that they can do is to give medication that you would give in menopause to see if you can help those symptoms, especially when they're getting to this point, if they're interfering with their life and they're somewhat starting to be almost dangerous, then certainly you need to do something. To be told that it's not typical side effects is probably not understanding the medication. Certainly a lot of the gynecologists that treat this disease and a lot of the patients are petrified of this medication. They don't maybe understand the role of a GRNH agonist. Certainly when you're dealing with a disease that's hormone sensitive and you give hormones, that may not be the best idea, but there are some patients where if you do stop their hormones, there are some patients that get some benefit from it. I'm not saying it treats the disease, but it treats some of the problem.
Okay. All right. Dr. Arrington?
I similar to that. Like John said, or Dr. DeLumba said, they're not common side effects. I don't see a whole lot of patients with looprun, but there are things that can happen that we may not be able to explain completely. But I think from what she describes easily could be related to the looprun and the effects of that. Theoretically, the effect should be, if it is caused by that, the effect should be able to come back to be helped with add back hormone therapy, whether it's northinder or more commonly would just be to supplement the estrogen back. It's not that the body can't respond to the estrogen that is there or that they take, but that the body is not producing that estrogen any longer. So then it's just a balance between estrogen addition to try to overcome the effects of the looprun versus potential stimulation of the disease. That's the hard part, I guess, about something like a looprun is once you give it, there's no taking it back until the drug's out of the system. And we've talked, kind of bantered back and forth on various things that could be a potential role of the quote pill form of the GRNH agonist or antagonist. Is it something that would be more easily removed if there are significant side effects? In my practice, I can't remember the last time I prescribed it, but it's clearly we all see patients who have used it in the past, and like Dr. DeLumba said, some patients will have benefit for the period of time that they're on it, but there are a lot who don't do well on it, don't feel well on it, and even some that have lasting side effects from being on it.
One of the things I would like to mention is, we're talking about an injection form. There actually is a nasal spray called Cinerel, Nafrolin, that you take twice a day. So if somebody's concerned, especially in the beginning, on how they would respond to this type of medication, that's something to think about. Of course, the cost is sometimes cost prohibitive, but I just wanted to mention that it's not always there for a month.
One of the questions is, how long has a patient been on, the person who's asking the question, how long has she been on the looprun too? Because in the first few weeks, you get this big spike of estrogen and progesterone about 2 weeks after you get the looprun shot, and that can cause all kinds of wackiness, because you have a real disorder of the hormones at that point, and then it's going to go down to having almost no estrogen and no progesterone after that. And if it's been months, then you're at a steady state. If it's really only been a few weeks, then things will be changing rapidly. And the low-grade fevers, I always sort of a question. People have hot flashes when they're on looprun. I always sort of a question in my mind. I was taught in medical school residency by people that may or may not have known what they were talking about, that hot flashes aren't actual fevers. But I have seen people that the only thing I can seem to attribute their fever to is that they're having hot flashes, because they don't seem to have any legitimate reason to have a fever, and yet they indeed have a high temperature. So this high temperature may be that. I don't know what you guys think, whether or not hot flashes are associated with legitimate high temperatures or not.
I've actually seen that occasionally also. The first time you see it, it's like, wait, this can't be. But yeah, I was nodding my head in agreement with you while you were saying that. How about you, Jeff?
I couldn't tell you one way or the other. It's been really so long since I've worked with menopausal patients in general.
I can tell you, I just had a patient who I removed her residual ovary for a particular reason, and she had 103 fever that night. And to this day, I have no idea why she had the fever. There was no infectious source found, and eventually she stopped being febrile. And she was having tremendous hot flashes. Like, she was telling me she was having hot flashes, and she had 103 fever. I have no explanation for that fever other than that it was hormonal. So if people, the books say that hot flashes don't cause fevers, but I'm not sure I believe it.
Libby, would you like to add anything?
Not really. The only thing that came to mind is that you've also got aromatase inhibitors, which can also be taken in daily form. Not the same as a GnRH agonist or antagonist, but kind of can achieve a similar effect. So that's another possible way of having trying something without having to commit for a month or 3 months. I don't know anything about hot flashes and fevers. I'll stay out of that.
Well, what Libby said, this new GnRH antagonists, you're going to be able to take them and then go off them immediately if you don't like them. So I think that's, once those come on the market, that may be the future for people that are wanting to take a looprun-like drug, which we can argue whether or not you should or not, but you're going to be able to take a drug that you can take orally, and when you stop taking it, it's out of your body within 24 hours. And I think that's the future of this line of medical therapy. I think that injectable looprun will be gone. There would really be very little reason to use it for the treatment of endometriosis, because it's the new thing will be expensive, but looprun is expensive too. So,
and the side effect profile seems to be a little better for the next generation, the antagonists.
Yeah.
See, at least from the studies so far, it seems to be a little less.
But just to that particular person, most likely when your looprun wears off, you're going to feel better. Now, whether or not you'll feel better from your endometriosis, who knows? But these side effects are probably related to looprun.
So what would y'all recommend? We've spent a lot of time on this question, so I'll try to quickly wrap this one up. But just to give her some hope and some light, it sounds like she's in a really dark place right now. What does she need to do in the meantime? Her OBGYN is not matching up the symptoms with looprun, and so they're not connecting, and she doesn't know what to do in the meantime. So does she continue to pursue him or just wait it out?
Well, I thought I thought she did decide with her OB/GYN that she was going to go off lupron, but until that time when it wears off, she certainly needs, in my opinion, some form of hormonal replacement therapy. I agree. Certainly in her case, I would probably start with an estrogen product, and then, depending on how she did with birth control pills in the past. If somebody does well with the oral contraceptives that have estrogen and progesterone, then you can do that immediately. Or, if she didn't do well, then I would certainly just start with an estrogen and then, if need be, a progesterone.
Perfect. Okay. Thank you, guys. All right. So let's move on to question number 2. We are going to begin with Dr. Fogelson on this one. Heather asks, my 10-year-old started her period recently. She has been complaining of a stomach ache. She's been cramping. Her tummy and bottom felt full. And when she raised her shirt, I saw how bloated she was, and it struck me. I'm shocked that her belly looks like this. It's so abnormal for her. I want to say I'm afraid because of my own experience in making way too much out of some bloating, but I also don't want to ignore warning signs with my kiddo like I did with my endometriosis symptoms. What do you guys think? I don't feel like an exam is appropriate for her yet.
Yeah, so it's a really good question. I agree. I don't think a pelvic exam is going to really change anything. I mean, I think that it's very unlikely that she has the kind of endometriosis that you would diagnose on a pelvic exam anyway, which would be kind of large nodules of endometriosis. I want to back up a little bit and say that a lot of times we get very focused on endometriosis, and there's a tremendous amount of human normalcy or pathology that is not endometriosis. And for a 10-year-old to be having some bloating associated with the onset of their menstrual cycle is probably not that abnormal. Now, is it possible that she will go on to have issues with endometriosis? Yes, it's possible, but I would not perseverate about that right now. I would give her Tylenol or ibuprofen and teach her about the fact that her body is changing and she's developing a menstrual cycle, and this is part of it. And giving her a label of a disease state that's going to bother her the rest of her life potentially, I don't think is really particularly beneficial for her at this point. I would also potentially, rather than going down the road of if one wanted to get help with it, rather than trying to seek out an endometriosis specialist, I would probably work with an adolescent gynecologist or a pediatrician, and someone that is going to look at it a little bit less invasively right now. I probably would not, even though we do operate on young women, I certainly would not be quick to put a scope in a 10-year-old. I don't know I'd be happy to hear what other people think.
Jeff, you want to go next?
Yeah, sure. I agree with that a lot. The chances that you would find in a 10-year-old endometriosis to the level that it is being, I like to call it destructive endo, that type of stuff that really steals their life, that steals fertility. I think very, very unlikely to find it that early in a 10-year-old. And I really, in my practice, I tend to try to treat them hormonally first with the goal that we want to make her functional. If it does develop into pain and endometriosis-like symptoms, while she's in her early mid-teenage years, if we can keep her symptoms controlled, keep her happy, let her, be a kid at school and participate in all the things, then I think we're getting the appropriate benefit from potential hormone therapy at that point. The biggest thing she has going for her is a mom who is aware that this can be an issue. She is not a patient that is going to get into her mid-20s being ignored forever, because the mom, Heather, is aware of this as a possibility, and it will be followed over the course of her teenage years. Now, if they try the hormone therapy, again, assuming if pain becomes an issue impacting her school, impacting her ability to function, that if simple hormone therapies, birth control pills, that sort of thing, don't help her be functional, then I also don't think it's fair to make her wait until the early 20s before somebody tries to look in and say, let's see what's going on and try to remove and take care of any disease that's there to see if we can help her be functional. But I'm on the same line, I think, as Dr. Fogelson, that there's no problem, I think, in waiting and seeing what she does. She's got a mom that's going to be vigilant, and I think that she's one of the lucky ones for that. Not just somebody who says, oh, that's normal, everybody goes through it.
Absolutely.
Well, I have a different opinion. I look at this disease that impacts women's lives to a dramatic degree. Not every woman, but a huge percentage. 2 years ago, or almost 2 years ago, I was doing a presentation, and I said, how dare we sit back and allow our patients where we have to do bowel resections, cut the ureters and put them back together, cut holes into the bladder. To me, I want to get a disease as early as possible. Now, I don't tell patients at 10, 12, 14, 16, 18, or at any age when to have surgery. What I go is, these are the symptoms. These are the options. And I go from everything from doing nothing all the way up to a surgical approach. And I want to get a disease early. Certainly, yes, masking the symptoms with hormonal therapy is an option, and some patients opt for that, and they do very well for years, decades, maybe even the rest of their life. But I don't want to hold surgery back because they're 10. I've recently, one of our past experts who's retired, Dr. David Redwine, huge pioneer. He always feels that, or he has felt in the past from what I've talked to him and read, that he likes this, he feels that this disease, in my opinion, comes out over time, and that if you operate too early, you're going to miss it. Using the 3D with the robot and also Firefly, I feel that you see a lot more endometriosis. And there was a paper published earlier this year that did compare 3D to 2D. And anywhere from 25 to 40% more endometriosis was visualized with the 3D. And that 40% was in the teen group, because it is much more atypical looking. You see the clear lesions. Anything could potentially be endometriosis that you might not see in an older patient. But that's how I approach it. And I've seen not only just endometriosis in the young patients. You can when you take out an abnormally appearing appendix, and also before you would even do surgery, this is a type of patient that I would certainly want to have a colonoscopy to make sure she doesn't have Crohn's disease. So there's a lot of things that have to be evaluated before you would just jump into surgery. But certainly, if she's bloating, that's not the typical symptom you may see with endometriosis. Of course, everybody says the endobelly. I think there's other causes of that. But I look at it that even Jeff and Dr. Fogelson always mentioned that their lives are interfered with, and I don't want them to go on so they're in their 20s and 30s and 40s having huge major surgery and decrease their risk of a cure.
Libby?
My advice would be to keep a track of the symptoms and whether they're worsening, how it's impacting her over the course of 2 or 3 months. I'm kind of in the middle, I would say, as far as opinion in terms of when to take action. I think that rushing to a specialist the first month after she started her period seems a little bit too kind of eager. I think give her time, see how she does with home remedies, over the counter, pain medication. Maybe, she could try birth control, see if she tolerates it well, but don't let it go on for, years. Have a set time over which, is it helping, is it not, is it getting worse? And if it's getting worse, then obviously that would make it more urgent to seek a professional opinion.
I think that sometimes we have to be open to say that we don't know. I mean, I think that there's a lot about this disease that we don't understand. I think that some people I firmly believe that the disease of endometriosis is more than one disease state. I mean, genetically, it has many different pathways. And the woman that has mild endometriosis when she's 14 years old, where you see lots of tiny little lesions in the pelvis, may be a different woman than the woman who has stage 4 endometriosis when she's 28. Like, we don't really know that one begets the other. I think that we would find that those women actually are expressing different genetic mutations and did one become the other mutation, or did they have a different pathway the whole time? We don't really know the answer to that. I don't think that stage 1 endometriosis necessarily becomes stage 4 endometriosis. Certainly we know that in ovarian cancer, stage 1 ovarian cancer doesn't necessarily become stage 4 ovarian cancer. Like, people start with stage 3 ovarian cancer very quickly. We know that now. We used to think that it grew, but it doesn't seem to. These are genetically different diseases. So I think these are things that we will find. And I'll be honest myself. I know Dr. Dulemba's, been doing this a little longer than I have, and Jeff and I are fairly similar. I've operated on 15-year-olds that had kind of mild vesicular lesions. They had tremendous pain, like all the symptoms of endometriosis, and just a few small little lesions in the pelvis, and you remove them and they are positive for endometriosis. And the question in my mind is all the other peritoneum that looked very normal, that I'll agree, but to me it looked entirely normal, and I think I'm pretty good at looking at subtle endometriosis. If I had gone back and removed that other peritoneum, would it have also been pathologically positive? I don't know. I mean, if one of you guys has the answer to that, I don't know.
Okay.
Yeah, can I just pop in real quick, Brittany?
Yeah, go ahead, real quick.
I think all of us are really not all that far off. The main thing we want to do is get these young women and get them treated before their disease gets destructive. If that requires a surgery in the early teens, fine. If not, I don't have any real data to back this up other than my own experience. But if you have a patient who has had painful periods through her teenage years, is missing school because of her period pain, she is very high risk for endometriosis, and we know that.
Right.
And I personally think it's appropriate if we can treat her hormonally and keep her controlled and keep her functional in her daily life, that we can delay that initial surgery. But still, I tell them I would like somebody to go and look at early 20s, 21, 22, so we can, if there is endometriosis there, we still have a very high chance of removing and treating this disease before it has the chance to really steal her hopes and her dreams. That's assuming that her symptoms are controlled well enough to allow her to function.
Jeff, I'm curious, why are you choosing arbitrarily 21, 22?
Again, that's purely just based off my experience. I have yet to see someone younger than 22 where, even though we may do some bowel work and even though, may do some extensive endo work, I have yet to see, 21, 22-year-old where I couldn't get the disease removed and be worried about her fertility. And again, I am sure and I am positive there are some patients out there who do have that impacted earlier on. Just in my practice, it's purely an arbitrary, my experience number.
And I would tend to agree with that. The youngest I've ever had to do a bowel resection is 25. But and I do agree that before the age of 20, this disease is rarely in the severe stage. It's going to be certainly easier to get. But again, once it seems like past 20, 21, that it is much more aggressive disease, in my opinion.
I can say there are exceptions, though. I would say. I mean, it's unusual, but I mean, I've seen with Andrew Cook, he's had not a huge number, but he's had maybe 10 teenage patients over the years who've been stage 3, stage 4. I mean, I remember I spent a day watching his surgery when I first moved to the US, and one of the patients just happened to be, it was a 17-year-old with stage 4 endometriosis, almost invading into the vagina. I mean, it was a full stage 4 bilateral endometriomas. She didn't need a bowel resection, but it was close. I mean, it was a severe form. So you do, I mean, but the point is, with a patient like that, you'd be able to see it on imaging. I mean, it's not, they knew going in that she had severe disease. So it does happen, but that's it's rare.
I'd be curious, Libby, if that patient had been on hormonal therapy to mute the symptoms.
I don't think so. No, I think no. I mean, she was young. I don't think so. In fact, she was pretty much asymptomatic, if I recall, until shortly before. And she'd had her appendix removed. I think they thought she had appendicitis, and then they discovered. So that was a separate surgery. But I think in her case, it was kind of a out of the blue, severe case. But
We do see patients like that all the time, though, where their pain even can be controlled for years and years and years on hormone therapy, but yet clearly the disease has progressed to the point of being a destructive disease. We basically, no matter when we go in, we want to go in at a time that decreases their risk of having their life completely changed by it.
I think part of the issue is so many young teenage girls will have problems with their periods, will have some pain. And if you take the same aggressive approach of each of them, it's not necessarily going to serve the majority. That's the question. You're trying to find the best treatment for the majority. And if you scare the pants off of every mum who brings her daughter in at 10, and say, well, she's going to need a bowel resection in 10 years or whatever, you know what I mean? Paint this picture of it's not necessarily, I'd probably, 7 out of 10 are going to be okay. I don't know what the numbers are.
You may not even have endometriosis. I mean, I think what you said, Libby, is very, very important. I mean, we're all endometriosis surgeons. Like 90% of the cases we do, or maybe for me, 80-90% of the cases I do are endometriosis related. And so you can get a very skewed view. I mean, if you ask a gynecologic oncologist how often is an ovarian mass cancerous, they're going to tell you 50% of the time, when the reality is probably 5% of the time or 2% of the time. And because all they see is cancer every day. So and I think that to some extent, people that not only have doctors that have endometriosis, but also women that think about endometriosis a lot, sometimes we'll see endometriosis everywhere when there are other disease states, there are normal painful menstrual cycles. In the end, this young lady needs to find a doctor to follow her, and if she's not getting better over time, she needs to potentially get scoped.
Well, don't forget, this is a patient who, or the mom has endometriosis. So
right,
I think there's an increased risk of this patient being at risk for endometriosis.
And that's the number one.
That's true.
Okay. All right, guys, let's move on to the next question. We're going to begin with Dr. Arrington on this one. Cindy asks, I would like to hear what can be done for women who still have endo after menopause and after multiple excision surgeries and a total hysterectomy. No ovaries, no uterus, etc. I personally am 59 and still have daily pain, daily diarrhea from endo-caused bowel resections, and periodic horrific cramps. I've tried it all, and I mean all. So please do not recommend pelvic PT, hormonal treatments, acupuncture, herbs, oils, electric, spinal implant, etc. I need a real solution, or at least real help.
Let me try to split it up into a couple things. Now, I'm focusing first on just what can be done with women who have endometriosis in menopause. And I think at that point, really, it depends on their symptoms, how much it's impacting their life. Clearly, if there's endometriosis there that is impacting their quality of life or in any way, then I think most of us agree that surgical removal of the endo is the right thing to do. The largest single piece of endometriosis I've removed was from a 54-year-old menopausal lady, had her uterus and ovaries removed out 10, 15 years before. 10-centimeter mass growing through the vaginal wall and into the sides of the pelvis. So it can happen. And really, in Cindy's case, there's just so much information that we don't know specifics, how aggressive was the excision. We do see patients who have hysterectomy, have ovaries out clearly without treating the endometriosis. But we also see patients where they recognize the endo in the bowel, they go in and focus on treating and doing the segmental resection for the bowel, but yet there is endometriosis elsewhere in the pelvis. So if there is a risk for continued endometriosis and it's impacting her to this level where everything she's tried is not helping, she's still in pain, then there could be a benefit of another surgery, by an endometriosis specialist more experienced with recognizing the atypical forms of the disease. As far as a lot of the other symptoms that she describes, the daily diarrhea, again, that could be related to the bowel resection. Depending on what bowel was resected, how much was resected, different nerve involvement, patients can get what we call a dumping syndrome with more extensive colon resections, where they just don't have the length of colon or the ability to absorb the fluids back in, and therefore they come out runny. Horrible cramps. She's already gone through the pelvic physical therapy and things like that, but we got to remember too that even though part of the bowel has been resected, there are patients that do have other bowel disease that could play into it. There's just so much in there that could be a player that it's hard to really comment on this specifically without knowing more details, looking at surgical history, looking at pathology reports, doing an examination, all that sort of thing. But again, going back to the original, menopausal endometriosis is horrible for some patients, and in those patients where it's very likely to still be present and it's impacting their lives to this degree, then I think most of us would agree that the most appropriate step is removal of the endo.
Okay.
Dr. Fogelson?
Yeah, I mean, I think that if you think that there's I always evaluate when people say they've had excision before. It's great if we have video of what was done. It's great to review operative notes. There are many levels of excision. There are people that are still early in learning excision, and they believe in excision and they do some excision, but they're not really ready to really thoroughly remove the disease. And there are others that are much more aggressive and have the skill set to do that. And so it's always a question. I mean, has the person truly had excision surgery from someone who's legitimately good at it? And do we think that we can get more out of doing something that maybe was missed before? When I see a patient who's had previous excision and they've had excision by someone who's really good, like Jeff, or I've seen patients occasionally, maybe that have seen you, Dr. DeLimbo, or Ken Sinervo, or other people, I look at that different than if I see that they were operated on by someone who I don't even know their name, and then I read the operative note and they excise some stuff, but they don't really describe the anatomy in detail in the way that I would think that one would dictate it if they were really doing thorough excision. Now, if the person really had a bowel resection, then that would imply advanced work. But the question is that with someone who's really expert in endo, or is it from someone who's less expert, but that involved a colorectal surgeon who maybe also doesn't do a lot of endo work, and possibly they left a lot of disease behind? I hesitate, though, to say that if you didn't get better from surgery, you just need more surgery, or that if you didn't get better from surgery, you didn't see the right surgeon. I do see that idea propagated online sometime, and I see women getting frustrated with sort of the sense that there's one magical surgeon out there that can fix their problem, and they bounce from doctor to doctor, sometimes paying a lot of money to see other physicians. So, but each case has to be evaluated very individually. I can't give this particular person specific advice other than you have to find somebody you trust to really thoroughly evaluate things, but also definitely look at other issues. I mean, talk to the colorectal surgeon that did the bowel resection. I mean, how much colon is left? Is this really something that maybe this is a functional issue that can't be addressed because there's colon missing that we can't put back? But maybe one needs a colonoscopy. But it's a challenging problem. But in general, in postmenopause, removal of endometriosis can be beneficial. But John, I'd love to hear what you think as well, and Libby as well.
Hey, John,
Yeah,
real quick before you jump in
Mm-hmm.
and let you just take over. That's if I don't totally blank on what I was going to say, which I think I did.
That's okay.
No.
Go ahead and I'll come back. I totally just blanked.
That's okay. Well, I certainly agree that endometriosis may be contributing to some of this lady's pain. What I've seen in the past is that when you have daily chronic pain, and oftentimes when we say stage 4 endometriosis, a lot of times that's from adhesions. The same thing with what might be going on with this patient, especially with the bowel resection, so many surgeries. I'm sure she had a lot of disease. And when organs start to stick to each other, specifically the bowel, you see a lot of things, including bloating after meals. You can see things like diarrhea because when you have hairpin turns, sometimes it's easier for that looser stool to get through there versus more firm stool. And when she talks about periodic horrific cramps, I was in Nigeria a year and a half ago, and trust me, I know what cramps are. And if a patient has even a half of what I had, laying on the floor, doubled over in pain, like, how do these women live with any of this? So I know that intestinal cramping is horrific, as much as you would see with ovarian pain, ureter pain, uterus pain, anything. So I think on that daily basis, I would put a lot of emphasis on adhesions and what you should or can do for adhesions, and then trying to prevent that from recurring.
Libby?
Hey, it's Jeff. Can I jump in real quick? I remember.
Yeah. Go ahead.
One thing that I think may be helpful in patients like Cindy, that if you have someone close by that is familiar with advanced endo, or in my neck of the woods, clearly I do a lot of advanced endo, but I also have the luxury of a pelvic pain focused clinic at the university, that if you can find somebody in this realm that can be and is willing to act as the point person, this is something that is going to take multiple specialties to evaluate, to look into, multiple different areas. But if you have someone who is empathetic to the endometriosis and the pain patient, someone who is willing to work with that patient and willing to be the point person on sending out consults and gathering information and reviewing and following up, that can be helpful as well in the endometriosis world.
Thank you. Libby?
Don't have much to add. I think that the specificity and the pattern of the pain and the triggers, that can be informative. I mean, with endometriosis, often the pain can be reproduced on exam. But when a patient says, my pain's 24/7 and it's everywhere, they're generally less likely to respond to surgical excision. I think that's what I've heard. I'm curious if the physicians agree. Than someone who has a very specific pain that can be, reproduced on the exam. You know that there's an area of tenderness, and you kind of have a hunch that if I remove that area of tenderness, they're going to feel better. So that can be a useful, findings on exam as well as imaging can be quite important as well in determining whether another surgery might be useful or not, and also detecting the mobility of the organs. Now that's not very, perhaps not, I don't know, for intestinal adhesions that might be rather tricky to assess other than just via surgery.
Libby, along those lines, I think the whole idea of neuropelviology that's kind of coming to fruition and being looked at, to me is fairly exciting and interesting, that we can learn a lot, just the distribution of the pelvic nerves and how that relates to our findings at the time of surgery. For me has been very interesting and fun.
I agree completely.
I don't know if either of you two were around in the mid-90s during when we used to try and do awake laparoscopies.
I was around. I was just 18 years old.
Yeah, I had heard about it.
Nick was doing other things.
I was
Me too.
I was aspiring to play golf on the PGA Tour at that time.
But no, we tried it. I didn't do as many as some of my friends up in Canada, but you learned a lot about the distribution of nerves and how little we do know, especially in the pelvic area, what caused pain, what might not cause pain, and it was a fascinating time. We don't do them anymore like that, awake laparoscopies.
Yeah, I know. I talked to David Redwine about it at one point. It was an experiment, but ultimately people have trouble having not pain from the laparoscopy enough to recognize what pain is diagnostic and what is just truly making the laparoscopy painless seems challenging.
Right.
Okay, let's move on to our next question. We're going to begin with Dr. DeLemba. Now, this is going to be regarding specific hormone testing and explanations of the testing. Michelle asks, what does the latest data on hormone receptors sites mean in terms of learning how endometriosis is driven?
Well, I don't know if driven is the correct word. Mr. Jeremy Wright, who's semi-retired in the UK, he's the one that sort of came up with this after the WHI, the Women's Health Initiative, came out 15 years ago. And they looked at breast cancer and its relationship to hormones. And so Mr. Wright and I sat down and we said, why don't we check our endometriosis specimens the same way it's checked as if it was breast cancer, and you send it to the pathologist. You look for estrogen and progesterone receptors. And that's what I've been doing for almost 13 years. And it's fascinating to me, for one, that I think, Jeff, I've asked you to try it, and other docs, and I know that about 4 or 5 years ago, I flew out to other doctors and said, please, if you don't believe my information, just do it on 10 patients, just order it. And even Dr. Cook, 2 years ago, I said, Dr. Cook, why don't you do it? And nobody really wants to look at that. And what I found is that several things. One, that 75% of the specimens that I see and it's not just one specimen, it's every specimen that I take out except for the uterus, tubes, and ovaries. I check it for estrogen and progesterone receptors, and 75% are positive for both. In the younger patients, I see a predominance of progesterone receptors over estrogen receptors. And then sometimes in the same patient in different areas, and this goes back with what you'd mentioned, Dr. Fogelson, I sometimes see different receptors in different areas in the same patient. I even have one online right now on my medical Facebook page where, she has an estrogen receptor positive specimen, a progesterone only, and then all the rest were both. And it's just fascinating. And it seems like it does not matter whether they are in menopause with no hormones. They are anywhere in their cycle with their own hormones, artificial hormones, like birth control pills. It doesn't seem to impact the receptor status of what the pathologist is going to see. And so when I said 75% are positive, it does seem also that as the disease seems to be more advanced, that it is more than likely going to be both. So I do agree with what you mentioned earlier, that it seems like this disease does change. It's not the same in the same patient. I see some patients asking, gee, can I have some of these, tested? I had my surgery 3 years ago. I'm like, no, they have to send that specimen, and have it checked at that time. And it's not a blood test.
Well, they still could. Why do you say they couldn't do it? You could, the blocks, if they still have the blocks, they can do it for sure.
Okay, if they still have the blocks, yes. But,
they keep them for years.
Some people think that you can go ahead and just do a blood test. And I'm like, it does not have anything to do, as far as I'm concerned, with, getting your blood levels checked.
Right. But typically those pieces of tissue are in wax somewhere in some warehouse. And could be brought out and cut it and restain it.
Yeah, I don't know much about pathology. So
they keep them, they're kept for a long time, just like medical records. The question I would ask for you, John, is that I think it's fascinating. And I think from a research point of view and publication, it's totally worthwhile. I don't know what to do with the information, though. I mean, are you doing something? Are you recommending to some patients that medical therapy? I mean, I wonder if certain patients would benefit from medical therapy more because they have receptor positive or negative. I mean, the other thing is we don't know what's on the other side of the receptor. I mean, the fact that there is a receptor means that the cell has the mechanism to listen to a signal, but we don't know what that signal is doing. So I'd love to hear what you say about that.
Well, for one, I might not have that answer either, but certainly to just make the assumption that this disease is only driven by estrogen, I think is worse. To sit there and just accept that and not even evaluate what might be going on in that patient, I think is doing almost harm to our patients versus actually trying to help them. So to answer your question is, when I sit down with the patient afterwards, we're doing the post-op visit, and we've got the report, and fortunately my pathologist puts into a nice graph, so we look at it. And when she wants to decide what direction she wants to go, because we know that in the majority of patients, their own hormones are not their best friend, because this disease grows, in my opinion, with their own hormones. Now, you might want to blame estrogen, you might want to blame whatever you want, it's growing with their own hormones. With birth control pills, I feel that it's still growing. It might be growing less, because if birth control pills worked, I'd be doing something else right now, because birth control pills do not make this disease go away. Dr. Arrington had mentioned, and you had mentioned, yes, you make the patients feel comfortable, they can function and fine, but it's not stopping the progression of this disease, in my opinion. Now, when we're sitting there and they want to do nothing, I'm like, great, that's fine, but I've excised your disease. But I don't know if every human being that says they do excision gets every single cell. I know some say they do, but they may not.
I don't believe it. I don't believe that you do it either. I don't believe that any of us get every single cell.
Well, and I tell my patients, I say I do my best, and I think I get it all. But, of course, I challenge doctors, if you're so good, go start doing cancer surgery because look at all the lives you'll save. But realistically, the patient understands there could be a cell somewhere. And if it's related to any of these, you take your own hormones or birth control pills or whatever receptors are there, it has the potential, in my opinion, of stimulating. Now, and then they make decisions based on that, versus just saying it's estrogen and trying to just give something to avoid estrogen.
Well, I think by and large, I'm looking forward to a future where people think about endometriosis in a very thoughtful academic way and really are excited to find out more about the disease. I think that we had this very simplistic idea of, okay, it's retrograde menstruation. It's never going to go away because it keeps coming back. So you just put on birth control pills. You can go in and cauterize it. It may work for a little while, but it's never going to work. Okay, so that was one idea. Then we moved to this idea of, okay, excision is what it's all about. And now that we understand that, the answer to all endometriosis is to cut it out. And anyone that thinks differently is a heretic. And any doctor that thinks differently is an idiot. And we have those two things. But think about cancer. Think about the way that cancer is thought about. Like, I have a friend, unfortunately, who has colon cancer at a young age. If there's a very specific cell type of colon cancer that he has, this microsatellite instability, it turns out there's one very specific chemotherapy that's going to work great for him. But it won't work at all for someone that has a slightly different cell type of colon cancer. So I really want to get to a point where we understand that not everyone with endometriosis has exactly the same cell type or exactly the same disease, and that some people may do great on birth control pills and it may keep them from advancing for the rest of their life. Some people may need to have excision. Some people may need to have a combination. Some people may develop a genetic therapy that attacks the very underlying nature of the disease. That any theory of endometriosis that says that I understand it all and one treatment's going to work for everyone is destined to be wrong. I truly believe that.
Mm-hmm. I don't disagree.
And so this information about receptors is going to be important. I mean, I think that I don't know what to do with that information as far as treating patients, but I think that creating studies that look at banks of people that have receptor positive and negative and then look at how they respond to various therapies is going to be crucial to understanding the disease. So I hope that you're keeping that data in an organized way and that we can all publish it.
Dr. Lemba?
Actually, I'm not, but go ahead.
Hey.
What's wrong with you?
I'm lazy. I'm lazy with paperwork, but go ahead.
Looking at the cellular biology aspect of this, to me, that should be a very straightforward benchwork, basic science study that could be done to activate those receptors and see what their effect is on the surrounding tissue. Just to see, if they're fed progesterone, does it stimulate growth? If they're, or fibrosis, if they're fed progesterone, does it make them more apoptotic, that sort of nature? Interesting thing you mentioned too, that you tend to notice in more advanced disease a combination of both estrogen and progesterone receptors. So that would be interesting too. Could we end up using that receptor knowledge if combined receptors in an endometriotic lesion puts that lesion at higher risk for deep invasion? Then I think that's important information to have. We can follow and track that patient differently. And I just think for right now, there's just the effects of that just to me are not known enough to really put that into full practice.
Well, one, I would challenge every doctor to start doing it and look at it on your own. It's not difficult to order. It's just tell the nurse to write on, I want estrogen and progesterone receptors on these specimens. Again, breast cancer, 65% are positive for both. And of course we would, if we had a breast cancer patient positive with both, I don't think any gynecologist would give them birth control pills. That just wouldn't be something you would do. One of the things that I found fascinating also is that it's not just the glandular cells or stromal cells that are showing some of these receptors. By the way, some of these receptors, an occasional, have no receptors. Exactly what you would see also in breast cancer. But one of the things is I'm seeing fibroblasts and mesothelial cells with some receptors. You know, talking to
what you need to do is when you have an ordinary hysterectomy from someone that doesn't have endometriosis, check the receptors on some pieces of
I don't have those.
Well, I occasionally do. But I mean, really, to be a little bit more rigorous about it is check receptors in non-endometriosis tissue and see what you have as well, because you might find some of that as well.
And certainly it's a possibility, but maybe they did have endometriosis and you just didn't know it.
Maybe.
Because I think there was a paper back.
Well, what about men?
There's a snake
Find a colleague
right now.
Find a colleague who treats, prostate cancer and have them. No, I'm joking.
But no, men can actually have endometriosis.
I know, well, okay.
Libby, did you have anything to add to this?
I
If
mean,
not,
my understanding is that estrogen and progesterone receptors are quite common, in tissue. I mean, that's why women who are plunged into menopause when they're put on looprun or other drugs tend to not fare too well, because the tissue throughout the body responds very well, responds to changes in hormones. It's not just, going to be present in endometriotic tissue. The other thing, it seems like the consensus in the research community is that, the finding of progesterone receptors is generally disregarded as relevant, because the assumption is that increasing progesterone when those receptors are present doesn't translate into increased activity of the disease. So that's really the question, how they came up with that conclusion. Is it based on actual endometriotic tissue, or is it based on studies looking at native endometrium and how native endometrium responds to changes in hormones? I mean, that's the question. The assumption at the moment is, estrogen bad, progesterone usually good, unless the woman is progesterone resistant. So that's the question.
And I really think that the push to use birth control pills in endometriosis patients really stems from what we know the effects are on the normal endometrium, which don't necessarily correlate.
Yeah. Again, what I find fascinating is in the younger patient, specifically the younger patient, but it can be in older patients, to see different receptors in different areas. I mean, to me, that makes this disease so much more confusing and even more difficult to treat when you look at any type of hormonal treatment, giving or taking hormones.
I hope none of the audience is frustrated that people are asking specific questions and you have 4 learned people all saying, we don't really know. What's the next question?
Welcome to live endometriosis. Okay, so this one is going to be for Libby. We'll start with you. Jennifer asks, how can we force getting more doctors and ER personnel trained and taught the reality of endo? No one should go into the ER like I did last night, and they tell me they have no reason for my severe pain, and there is a ton of fluid and all, but they don't know why I'm in pain. But when I bring up endo, they say no and brush it off.
Good question. I think implanting some endometriosis into all medical students, and not, no, I'm joking. Part of the issue, I think, is, there's a lot to cover during the years that physicians spend at medical school, and not just physicians, but, medical professionals. And so endometriosis usually doesn't get much attention. Women's health maybe doesn't get that much attention. So they might get a lecture on it, which may be with some rather outdated ideas. And that's kind of it. The fact is I don't remember what the percentage was, but I remember hearing at one point for GPs, general practitioners, and in the US they're often referred to as PCPs, a good percentage of their patients will be women with menstrual health related problems. It's a very common issue that they should encounter every day. So you would think that they would be very familiar with conditions like endometriosis, or at least it would be very advantageous for their patients if they were. So I think that, education should certainly start with, improved guidance for PCPs and GPs, because they're kind of often the gatekeepers to further healthcare. ERs don't generally seem to be the best place for endo patients, and obviously when someone's in awful pain, they'll go to the ER, but it would be much better that they don't slip through the net. They go to their PCP, they get referred to somebody, a gynecologist who knows how to address the condition preferably with a whole team of people who are kind of there to provide the support they need to manage the pain, so that when they're in a situation like the one where this lady had to go to the ER, that there is a different way for that situation to be managed. So she's not stuck in an ER waiting for a long period of time, low priority, because you might have other patients with gunshot wounds or life-threatening type situations. ER staff tend to be very overstretched. So I would say better education for GPs and PCPs. I guess more of a representation maybe of endometriosis at conferences that aren't just gynecology based, but more general medicine, so that there's more exposure. It's difficult to know how really to reach, and better training, I guess, in medical school, but that I'm sure there are countless illnesses where there are people saying, well, I wish that there was more time designated to you name what illness. And there's only so many years that we wouldn't have any physicians if we covered if every illness were covered in the satisfactory depth. They'd be medical school for 20 years.
Students at most medical schools don't really get mentorship with physicians that really do endometriosis work. I think that's changing over time, but I can say that there's still a lot of medical schools that teach very outdated thoughts about endometriosis, and they're skeptical of excision, and they're skeptical of a lot of things. And if you really want to be a really hard evidence-based person and say, until I see the randomized trial that proves that surgical management of endometriosis works, then you may remain a skeptic, because those really hard randomized trials are hard to execute, and there are a lot of heterogeneity of who the surgeons are and who the patients are. And so there's people that remain skeptical, and so the students come through, and if they're taught by the general OBGYNs of the department, they may not get taught what we would consider to be modern theories of endometriosis management. I wasn't taught that. I picked it up after residency, really.
The perfect response to somebody like that? It's because there is this sort of almost obsession with evidence, with randomized control trials, and if it doesn't meet that standard, then it's not, the treatment can't be justified. You just ask them whether they, in the event of jumping out of a plane, whether they would choose to take a parachute or not, to protect them from death. And there are no RCTs proving that parachutes would actually help them. And if they want to, blindly assign themselves to potentially assign themselves to a non-parachute group and jump out, and
right. Well, there are probably some anecdotes of people that have fallen out planes without parachutes that have ended poorly. But it's a challenge. Even in Portland, at OHSU, which is the medical school here in Portland, I don't think that the faculty there are particularly thoughtful about endometriosis. And there's one faculty member there who is on a couple endometriosis lists, and she's struggling with not being respected by her colleagues, I think. Even though, and so it's limited, but it's changing over time. I think there are far more, partially because of the AAGL. If you go to the AAGL, which is the American Association of Gynecologic Laparoscopists, you go to that meeting, everyone there believes in surgical management of endometriosis, really. Or if they don't, they're quiet about it. And, so if people want to become good gynecologic surgeons and are either in the leadership of AAGL or kind of join into that group and try to become involved, you can't go there and not realize that almost everyone there believes in surgical management of endometriosis. So it's, I think it's becoming better over time.
Dr. Arrington, do you have anything to add?
No, I think I'm good.
Okay.
Well, Jeff, you look like you're kind of sitting on your throne there, the way where your camera is. It's like.
No.
I'm good. Next question.
Well, no, for one, you can't force more doctors and ER personnel to believe in endometriosis. I think part of the problem also, along with what Dr. Fogelson and Dr. Arrington mentioned, that we don't have enough time in residency, in medical school. 4 years of residency, and most of it's devoted to obstetrics. And all of a sudden now they've shortened some of the time without extending the length of the residency. So, endometriosis is sort of ignored, and we focus on it because this is what we do. But even if the statistics of 10% of women have endometriosis is correct, personally, I think it's a lot more than that. Of course, I could be biased, but even 10%, that's 1 in 10 women. And as a gynecologist, I'm shocked every day that most gynecologists do not pay more attention to something that impacts a huge percentage of their practice. And so, but part of it is that, when you can spare maybe 6 minutes for an office visit, if you want to be able to pay your bills, if you're accepting insurance, you don't have time to really learn about this disease. And then when you come out of training, you're well versed in obstetrics, but maybe not so well versed in surgical approaches. And so all of a sudden you come up against a stage 4 endometriosis. You don't want to get there again. So you're going to stick with your C-sections and some easier cases. And so if you ask a patient about their symptoms and they start telling you, you're going to have to investigate it. So it's better to just bury your head in the sand.
I just want to add one other thing just to address this. Is that when people show up in the ER because of endometriosis pain, I think in some sense it's our failure as doctors to address something, which is that endometriosis patients sometimes have flares of pain. And if you have an ongoing relationship with if you're just a consultant surgeon and then they have another primary care doctor, that's one thing. But if you have an ongoing relationship with an endometriosis patient, I think that having a plan to how to deal with a pain flare should be part of management. So hopefully they don't end up in the ER, because the ER docs, they want to make sure you're not dying from something. And if you're not dying, then they give you some pain medication and send you home. Like they don't, ER docs aren't like making a diagnosis is not what ER docs do. I mean, it's like the 5th most important thing they do is finding out what's wrong with you. They want to make sure, A, do you need to be admitted? Do you need to go to the operating room? Or do you need to go home? Like that's, I've worked in ERs. I mean, that's like what the mindset of an ER doc is. And then if you don't need any of those things, then what do we need to do to be able to get you out of here? So you can't expect an ER doc to really make any diagnoses. And really, if you're in the large category of not going to die, they don't really care what's wrong with you. They want to do whatever briefly you need and then get you on your way. So we got to figure out how to keep patients out of the ER. But Jeff, you were about to say something. I'm sorry.
Yeah, and really it comes down, not only, we harp all the time about patient education and patients being educated, and social media is amazing for that, but the more educated a local community of physicians is, I think the better off for patients. I'm in a small town in Utah. The ER docs, they know what I do. The anesthesiologists, they know what I do. Most of the primary care in the area know what I do. And if they do have a patient that comes in, complicated, long history of pelvic pain, instead of sending them from the ER to the doc who's on call for the day, they'll give them my name. And that just comes down to them being aware that this is a problem and that there's somebody around that can help treat it. It's an education thing for the docs. Part of that comes from, most docs, honestly, even in my community, we have people making policy that probably haven't looked at an endometriosis research paper since residency. And there's just not a major push to really stay up on that disease, because that's not the focus of their practice. They're very well versed on new, maternal fetal medicine studies, on lung maturity in infants and all things related to obstetrics. But like Dr. DeLumba said, if their bread and butter is not with endometriosis, they're just not going to spend a whole lot of time researching that on their own.
Okay. All right, moving right along. We've got to get moving, y'all. All right, so these are also interesting. It's hard not to just keep going and elaborating. Okay, so we're going to start with Dr. Fogelson on this one.
Okay.
Carly J asked, can I have pelvic congestion syndrome with a total hysterectomy? I have had surgery at a top facility, I've had surgery at a top facility for endometriosis, and the past few weeks I am having pain. I have been through pelvic floor physical therapy, urologist to rule out IC, gastro consult with full colonoscopy and endoscopy, and all other basic OBGYN testing.
Well, the answer is yes. You have to know more about Carly's specific issues that she hasn't really revealed in that question to think about whether or not she could have pelvic congestion syndrome. But pelvic congestion syndrome is essentially varicose veins of the gonadal veins, which are the veins that come off the ovaries. And in some cases, some of the deep pelvic veins as well. The really characteristic sign of pelvic congestion syndrome is pain. It's a very heavy, dull pain in the pelvis that is present when you've been standing up for a long time. And if you lie down, you should feel better pretty quickly. So a patient that has pain and when they lie down, it doesn't get any better, that's not pelvic congestion syndrome, almost certainly. I mean, basically, you think about it like varicose veins in the legs, that you have blood sort of standing in the legs and it's not getting back up to the heart because the valves in the veins are incompetent, which means that what's supposed to happen is the blood is supposed to get pumped back up towards the heart, and every time it makes a certain amount of distance back to the heart, there's a one-way valve it goes through, and it can't get back to where it came from. So by nature, it's in a circle and it gets back to the heart. When those valves are incompetent and the blood can go backwards through the vein, then it allows you to have like a column of blood that creates a pressure on the organ that's being drained. And over time, that, in the case of leg varicose veins, it makes leg pain, and in the case of pelvic congestion syndrome, it creates pain in the uterus and pain in the ovaries. And congested ovaries can hurt. That's why an ovarian torsion hurts. Even a partial ovarian torsion hurts because the ovaries getting congested. So if Carly, I think it was Carly, if she has pain that is very notable when she stands and then she lies down and it feels better, then one could potentially look for a pelvic congestion syndrome. And the best way to look for it is either with a CAT scan or an MRV, which is either radiographic or MRI-based imaging of the ovarian veins. And typically one wants to work with a interventional radiologist who is really experienced with pelvic congestion syndrome. Usually they are not just technicians in radiology, but they'll have an office where you could actually go and talk to the interventional radiologist who has some experience with pelvic congestion syndrome. And if they agree that the symptoms are sound like it could be, then they may get the imaging and really look. But I'd love to hear what other people say as well.
Okay. Who would like to go? Libby? Nope.
I
Okay.
know nothing.
Jon Snow.
That's funny. Dr. Ferguson, that was great. I don't have much more to put into that other than it could be something other than the pelvic congestion syndrome. I'm a huge believer in adhesions as a source of pain, and that could also be contributing to it too.
Just observation-wise, again, going back through residency and training, all that, we were taught that one of the treatments for pelvic congestion is hysterectomy. That just by decreasing even though we leave the ovaries there, by decreasing the blood flow back through the uterus and the connection between the uterus and the ovary, that would take care of most pelvic congestion syndromes or symptoms. And maybe Nick or John pipe in on that. But just observation-wise, in some of the deeper endometriosis cases, I'll see what appears to maybe be a mass or a bulge in the deep pelvic side, while kind of down toward the back. And as I get in there, I'm fairly amazed at how large the internal iliac vein and its branches are, particularly some of those going down to the rectum. That again, don't know if that could potentially be a source of that varicosity, fullness type of pain. And it's only been a handful of times, but enough to where it kind of raises my eyebrows a little bit on how dilated those veins can be, even after a hysterectomy has been done. But we're talking a whole different vascular system there.
Okay.
Maybe.
All right.
No, go
All
ahead.
right. Let's move on to the next question. Dr. Arrington, will begin with you, and Delimba after that. All right. Gwendolyn asks, does anyone know if there's a way to stop your period besides with looprun, IUD, or a hysterectomy? Debating if I should get a hysterectomy. I'm 30 with no kids and never want children. Personal opinion, no hate, please. I've been dealt a very bad hand in life, no job or insurance, and no family or friends. A hysterectomy seems like a good way to get my life back. I know it's not a cure for endometriosis, but it will stop my ridiculously heavy bleeding. Lupron hurt my body, and IUD just sounds like another fill. And this particular patient has had 3 excision surgeries.
So I want to, I guess, approach this purely based on the heavy bleeding. And I guess essentially that's what the main question is. There are plenty of ways to do it. Lupron's one of them, but again, it's limited in duration and time. She's already been there, done that. Hysterectomy, clearly. Continuous hormone or continuous birth control pill can do it, skipping the fake pills in between. Daily progestin therapy, progesterone-only pills. Again, the Mirena IUD, even though that can sound kind of scary, is probably one of the better medical ways to try to approach it. As far as hormone effects in the body, it's probably one of the lowest hormone effects that go throughout the whole body. Most of the effect is local to the uterus and not even necessarily a great degree to the ovaries. But about 40% of women with the Mirena IUD will stop their periods altogether. Depo-provera can also stop the periods. A number of ways to do it. Surgically, there's endometrial ablations, which should not be confused with ablation of endometriosis. But somehow using some thermal or heat energy to destroy the lining of the uterus can be effective as well. A number of different ways other than what she mentioned to purely either at minimum slow the bleeding, at best stop it.
Okay. Good.
Well, actually, there is one other hormonal therapy, and of course, most patients go, "No, thank you. I'd rather hurt or I'd rather bleed." It's male hormone, like danazol, Danacrin, but nobody likes the side effects of what's called virilization, which is facial hair, increase in acne, weight gain, shrinking of the breast. Yeah, Dr. Vogel. But an increase in sexual desire. So there are some benefits to it in some patients. But again, that's just one more thing to try. And what's fascinating is that, like you said, Jeff, that birth control pills are an option, and the IUD and the endometrial ablation, Lupron, all of those are options. But when it comes to the male hormone, which there's no estrogen, there's no progesterone, maybe it'll have minimal impact on the disease itself, and she may probably not bleed, but nobody wants those side effects.
Well, I would just add, I think that one thing that's kind of underlying in her comment was that about I've had excision and should I have a hysterectomy? I think that there is a kind of a thing online about that hysterectomy doesn't cure endometriosis, and it leads people to ignore hysterectomy as potentially an additive thing that can be helpful in cases of all kinds of pelvic issues, whether it be pelvic pain, heavy bleeding, endometriosis. It is okay to include hysterectomy on the large menu of things that you could possibly do with someone that has endometriosis or other reasons for pelvic pain. It kind of harkens back to something I said before about being so radical about either endometriosis is a medical condition or you cut it out and that's it. It's like, okay, we generally agree that endometriosis doesn't come from leaking out of the uterus in retrograde menstruation. At least most of us agree that. But that doesn't mean, and so therefore taking the uterus out will not prevent recurrence of endometriosis. But that doesn't mean that taking the uterus out is always the wrong thing to do. And if a patient is clearly done with childbearing and they're having heavy bleeding and the uterus is causing problems, I mean, it is a bag of muscle to have a baby, and that is its purpose in the body. And other than that purpose, it serves no purpose. So now, unless you get into some kind of metaphysical idea about the seat of femininity in your uterus and so forth, which I'm not going to argue with, but there's no kind of scientific basis to that. I mean, that's almost a religious concept. So if you're really not going to use it to have children and you're absolutely certain about that, there's nothing really wrong with taking it out. And it certainly is going to make you not bleed anymore. And it may be very helpful with pain as well in a lot of circumstances. Now, I will say that there are plenty of 30-year-olds that say they don't want to have children, and when they're 40, the things have changed. I mean, as you get older, your hormones, your genes are programmed to reproduce. Life will find a way, as Malcolm said in Jurassic Park. It will, the body wants to reproduce, and your cognitive brain is fighting your genes, which want to reproduce. So a lot of people who decide they don't want to have children young get older and start thinking that they actually want to have children, and it's totally it's not cortical. It's like in your pons saying we got to get these genes copied. So I'll just say that.
Okay. All right, Dr. DeLimba, this one is at you. Amanda asks, my question for the discussion is, once you have endo, will you always have endo? Or can you have surgery and it not return? Also, what's the benefits of surgery? What's the best surgery to have? So there's a few questions in there.
Yes. So once you have endo, will you always have it, or can you have surgery and then not return? I mean, it's a yes to both of those, in my opinion. Certainly, you can have surgery and it not return. I think there's at least 3 or 4 different theories on the growth and development of this disease and how it's there. From one that you're born with it all, that there's backflow. You can even have what's called metaplasia, which is meta change plasia cells. That the cells can change, and maybe there's deeper cells as progenitors to these. So yes, you can have it gone and not return. But it also, if you have it, can you always have it? Yes. I mean, I don't care who the surgeon is. We had said this early in this meeting that there can be a cell left behind. You know, I have patients that have endometriosis in lymph nodes. So it's difficult, but not impossible, and it can be gone. So what's the benefits of surgery? One, I like surgery. So to me, that's a great benefit. That's the beginning. Certainly, if there's disease in there, you know, in my opinion, this is an immune system problem. And if you have a dysfunctional immune system, because these cells are there and your body can't get rid of it for whatever reason, which is beyond my capability thought process. So if you get rid of it like a splinter, an ingrown hair, then certainly it may be gone. And then maybe your immune system has a chance of getting rid of the cells that you might not have been able to get to, maybe even like adenomyosis. So getting rid of the disease, I think, gives that patient the best opportunity to have either all or most of her disease gone. And what's the best surgery to have? Whatever the patient wants. Certainly, I think if the disease is in there, I think cutting it out is the best, which is also called excision. I don't always use big words. So excision to me is the key. You're probably, and there's studies out there showing that excision is better than ablation, especially in more advanced disease. You know, should somebody have a hysterectomy? Again, it goes back, as Dr. Fogelson said, on what your childbearing thoughts are. If you have adenomyosis and you're bleeding and the uterus hurts, what about your ovaries? Do you have debilitating PMS? Do you have pain with your ovaries? Just taking out the uterus is not always the answer. It can be a good answer. Is it in the appendix? Is it in the bowels? Is it in the lungs? Is it in the liver? So the best surgery to have is the best surgery to get rid of the disease. Now, as a robotic surgeon, and I've done both, one for 11 years, one for 20 years, laparoscopy or robot, I think the best surgery, in my opinion, is to have this disease addressed robotically. Now, that's my opinion. There's other people that are going to have different opinions, whether they do or do not do the surgery. But I think there's, you know, more advantages to doing it with that. So, again, that's my opinion on that aspect. So I hope that answers, and I'll let the other guys jump in.
All right. Thank you. Dr. Arrington, would you like to add anything?
Really nothing too significant is coming to mind other than what he said. It all comes back to currently our best treatment option for the disease. Again, if the patient understands the risks and understands the potential benefits of doing the particular surgery that fits that patient's desires in life, down the road, ideally, would we potentially have a combination for, potentially incomplete surgery followed by medical therapy that gets rid of the remainder of the disease, or it becomes a disease that's purely treated medically. But for right now, I think treating the endometriosis disease, especially in advanced cases, and more often, any time it's significantly impacting the patient, currently surgery is the best thing that we have.
Okay. All right, Dr. Fogelson, this one's coming to you. Kelly G asks, As a 41-year-old, my OBGYN has me on birth control pills to control my symptoms. I honestly don't like being on them simply because I have had high CRP in the past. However, they do control my heavy bleeding, and I occasionally will miss a cycle altogether. I will still have what I call episodes of excruciating, debilitating pain. They are sporadic, maybe a few times a year. Do the pills just hide and mask the damage that endo can be causing? At what point is excision necessary? How do you know what next step is to relieve pain and future problems? It has been recommended that a hysterectomy would be my next plan of attack. Is that a typical option?
Yeah, I mean, it's a great question, and this is a fairly common situation. Certainly, birth control pills are going to continue to suppress the symptoms. Whether or not they suppress the progression of disease, I think most likely they do for the most part. I don't think it makes the disease go away, but I think most of the scarring and the additional fibrosis and scarring coming from endometriosis is mostly from an interaction between the body's immune system and active inflammation in the pelvis. So if the birth control pills are keeping the cells relatively dormant so that they're not creating a lot of inflammation and thus not a lot of pain, there is probably less immune action and therefore less scarring that is developing over time. That being said, I would say that disease is different in different people, and there certainly may be some people that have progression on birth control pills, just like some cancers will progress despite chemotherapy. I don't think everyone has the same disease as I mentioned before. These occasional severe pains, the question is really, in order to really answer the question, we really would have to examine her and really think about, okay, where are these pains coming from? I wonder if she is having an occasional severe pain, and if it's really central in the pelvis, it may be coming from the uterus itself, in which case a hysterectomy may be a great option, that it would eliminate those issues. If the pain is coming from endometriotic lesions, then removal of those endometriotic lesions may be beneficial as well. I think for a 41-year-old, if she's definitely done with childbearing and feels like the current state of affairs is not good to continue with, then a surgical option is certainly appropriate. I would encourage her to have surgery with someone who is experienced with endometriosis excision, and that either go in and just remove endometriosis or go in and remove the uterus and remove endometriosis. I think the mistake would be to kind of pluck the uterus out of a bunch of endometriotic disease and think that's going to fix all the problems, because you really have to remove all the endometriotic tissue in addition to the uterus to get the optimal outcome. Now, if she wanted to continue with a medical therapy, a Mirena IUD wouldn't be a bad choice, because she would likely become amenorrheic or not bleed at all if she had a Mirena IUD or a Liletta IUD, which is the other brand name of the same thing, inside the uterus. Within 3 or 4 months of having a progesterone IUD, she likely wouldn't bleed anymore. She could go off birth control pills. If she's having systemic effects from birth control pills, that'll be less so, because there's not that much systemic absorption with a progesterone IUD. And that would be an option as well. But, it's hard to give patients very specific advice without really, we don't have a doctor-patient relationship. Like the question about pelvic congestion syndrome is easy. It's like you're asking about a disease state. I can tell you all kinds of stuff about a disease state. But if you ask me about what you should do, well, I have to see you and evaluate you and do an exam and maybe imaging and then give you a really expert opinion. And so I often say, find a doctor you trust and then trust them, and if the doctor you're seeing doesn't seem to be knowledgeable enough, then find a better one. But once you find one that meets your standard of knowledge, that for whatever that standard may be, like you feel like they know what they're talking about, then take their advice, because they are experts. But they can't tell you for certain over the internet, unfortunately.
Sure. Okay. Anybody else want to add?
Along those lines, if let's say she or another patient were to go forward with hysterectomy, and let's say they do get in there, they're performing hysterectomy and see that there really is more advanced endo than maybe we expected, to just make sure that doctor is either willing and able to treat it, or understands the idea that the hysterectomies may not completely resolve her symptoms, and be willing to refer on if needed.
Dr. Fogelston, quickly, can you kind of give, I know that the details are limited, but can you kind of touch base on the possibility of the future blood test that could possibly diagnose endometriosis?
Sure. So, yeah, I'm actually a consultant to a company called Juno Biosciences, which is a genetics company in Utah, near Jeff, actually. They're in Salt Lake City. And they have had a lot of success at identifying genetic targets for what is causing endometriosis. And it's very eye-opening how many different genes seem to be associated with endometriosis. There are literally over 1,000 target genes and about 50 high-value mutations, which means mutations that when you see them, the likelihood of the patient having endometriosis is very, very high. And there's different types of genes. There's these single nucleotide polymorphisms, are called SNPs or SNPs, where there's over 1,000 SNPs that are associated with a higher prevalence of endometriosis. And then you have actual sequenced genes where you have the entire sequences that will code for endometriosis. And what's weird is that some people that have endometriosis in their family tree, all the people with endometriosis have a mutation that's associated with cell-cell interaction called a cadherin a gene, which is one of the communicating systems between cells, that they have a broken cadherin gene. And everyone that has that mutation seems to have endometriosis in the family, and the women that don't have endometriosis don't have that mutation. And then you have other people who have angiogenesis genes, which are genes that associate with how blood vessels proliferate. And yet, again, it's tracking with the endometriosis perfectly. So that mutation seems to be causing the endometriosis, and yet it's a totally different mechanism than the gene that is causing the endometriosis in the other women. So that's why I say that that endometriosis is not just one disease, because we have two totally different cell pathways that are causing the phenotype of endometriosis. And phenotype is, my genotype for my hair color is the genes that code for hair color. My phenotype is that my hair is brown. So the phenotype of endometriosis has more than one genotype, meaning there's lots of different genes that can code for the same brown hair, or endometriosis in this case. And so right now we have a test, I wouldn't say Juno Biosciences, of which I'm associated, has a test that will possibly come to market that we'll be able to tell with about 95% accuracy if somebody has endometriosis. And it's just looking at their genes.
It's huge.
And it's pretty interesting. I think right now it's rudimentary. I think right now it's not terribly useful, because knowing whether or not someone has endometriosis or not without more detail, I think, is not that useful. But when you get it to be really narrow, if we can start to say that who's going to have deep infiltrating endometriosis, who's going to have infertility, who's going to have pain that's going to respond to surgery, who's going to have pain that's not going to respond to surgery, I think all those answers are going to be able to be answered genetically. Because fundamentally, when two people with the disease, a given disease state, behave differently to a given treatment, it's because they're genetically different. It's not just because it's the wrong surgeon. Obviously, people can do bad endometriosis surgery, but when you have one person who has excision surgery and they are miraculously cured, and they run in the streets saying Dr. So-and-so is amazing and they fixed me, and then a different patient says Dr. So-and-so is a fraud, they did surgery and it didn't work at all. It's the same doctor and they did the same surgery. The difference is them. The patient is different, and it's not different in their head. It's not like they're trying to not get better. They're genetically different. And so I think that we will get to a point where we're able to determine which patients are going to be the best to operate on. I think we'll determine who will benefit from medical therapies, possibly even which medical therapies. And we may even develop new medical therapies that attack endometriosis at a very genetic level, just like, I think we'll reach a point with cancer that cytotoxic chemotherapy will be considered like barbarism, that I can't believe we did that, where we tried to kill every cell in their body, hoping to kill their cancer, just because the cancer is killed more than the rest of them. That's why chemotherapy is so toxic, because it kills everything, but it just kills the cancer more. One day we will look back at that and go, this is ridiculous. Why don't we just treat the genetic origins of the cancer? And we're getting there in cancer, like with chronic myelogenous leukemia. We can cure that disease with a very targeted genetic therapy that has absolutely no impact on the patient's body other than killing the chronic myelogenous leukemia. Brian Drucker at OHSU invented that, and I firmly believe he'll win a Nobel Prize for it. But that same theory will one day apply to endometriosis, and it'll put us all out of business. And I'm looking forward to being out of business from surgery when we can genetically treat this disease. So there is a test now. It'll be on the market in a few years. It's probably going to be not very useful in its early iteration. But I think that 10, 20 years from now, or maybe even maybe sooner, we're going to be able to know so much more by looking at the genes. And that was a very long answer. I'm sorry.
No, you're fine. That's very interesting.
That was fantastic. And you know,
Yes.
Dr. Fogelson, that kind of actually, that's why I would urge you, maybe on your next 10 patients, 20 patients, order estrogen and progesterone receptors. Because when you describe how this disease is different, to me, it fits exactly with what I'm seeing in their receptor statuses. I mean,
there's a big group of docs together, which John, I think you're a part of, that we're going to start this research group that's national. Are you part of it? Oh, you're not.
No.
Okay.
No.
So part of that study is probably going to be to genotype everybody in the study, and when we can categorize people as having different responses to surgery or different hormone receptors or different whatever categories you want to put them into, we can cross-reference that to their genetics, and we're going to be able to find some really interesting answers, I think. It's the answer to every disease. I mean, every disease is genetic. No matter what it is, it's genetic. And people always ask, is X genetic? It's all genetic. There's nothing that's not genetic. The question is, everything that happens in the human body is ultimately transcription of genes, which ones are being transcribed, which ones aren't. Epigenetics, which means your genes are getting changed by, like when people say that certain environmental toxins may be affecting endometriosis. It's possible because there's definitely environmental toxins that change your DNA and cause it to be transcribed differently. So it's a very interesting future, and I'm kind of happy to be 42 years old and not 65, because I think that in my career, no offense, in my career,
more than that.
I think that endometriosis is going to be very different 20 years from now than it is right now.
I agree.
And for anybody that says nobody's doing research in endometriosis, it's bullshit. There's so many people doing endometriosis research at a basic science level. I hear that, like, nobody cares about endometriosis. It's not true. There's a lot of people doing a lot of research. It's not as funded as you might like, but I mean, there's still a lot of people.
Awesome. I love to hear that, because I am one of those people that, we don't hear about the research that goes on in the endo community. It's very rare when, we see an article come by, and I actually did see an article about the blood test a while back, but so it's refreshing to hear that there is research going on out there. It gives a lot of hope, honestly. So.
Yep.
Okay, let's move on. This one is going to start with Dr. DeLimba. This is from Dolly P. She asks, why can't any imaging show endometriosis? I've had so many CT scans, etc., and the only way to see the endo is to do a scope. How can we eliminate cutting in order to see the damage endo is causing?
Well, for one, to me, to use a CT scan for the pelvis is probably the least informative or least accurate in comparison to an MRI or the ultrasound. So, more than likely she's gone to an ER, and that's what they do. For one, some of this disease is extremely small. When Dr. Redwine did some of his publications, in discussions, he would mention how close he would get to the tissue. I mean, we're talking about millimeters away from the surface. There's times when I'm looking at endometriosis, even with a magnification 10 times in 3D, and it's almost missed. So that's part of it. So unless there's a glob of it somewhere, such as an endometrioma in the ovary or an endometrioma elsewhere in the pelvis or a massive endometriosis, you're probably not going to see it imaging. So you need to actually do surgery to visualize it. So that's the first thing. Something like adenomyosis to me is a little more attainable on imaging, not because you can actually see the cells, but you can see the impact of the sound waves on the adenomyosis on the sound waves. So I always explain it to patients. The uterus is a muscle, and you can send sound waves through the muscle. And it's like looking for a submarine in the ocean, because ultrasound and sonar is in essence the same thing. So you set a gain at a specific level so it doesn't recognize the muscle. And when it hits glands, which are at different density, it may change that sound wave, and you can get a better visualization of adenomyosis. So, we could try to do that on the peritoneum, but the peritoneum is, thin, paper thin. So you couldn't get that same density flow of the gains of the sound wave through that muscle. So that's why we can't see it. Although I know of endometriosis experts that one got angry at me because I called him a name because he said unless he sees endometriosis on the MRI, the patient doesn't have it, and
that's ridiculous.
I don't disagree with you, and I said it different. I called him an idiot, and there were people around, and he didn't like that. So,
Okay,
That's
so
absurd. I mean,
what would
it's crazy to say that.
I know, and he's an expert.
Is he? I don't know.
Well,
Who is that?
So what
Like I said-
can you rely on the ultrasound and other testing pertaining to endometriosis before and after a surgery?
I'm sorry. Did I rely on?
What can you rely on? The ultrasound and other testing before and after surgery?
Well, I described about the adenomyosis that you can
Right.
look for. You certainly look for anything else like fibroids that may potentially cause pain, ovarian cysts that could potentially cause pain. Plus, I use it as a problem-focused exam. To me, better than the pelvic exam, because we do it for pain mapping. We look to see, are the ovaries stuck? Are they mobile? Where's the pain? If I push on the left, does it hurt on the right? Is the uterus painful or the ovaries painful? So it gives you a lot of information, even more than my exam. I also often joke, if anybody's ever heard the fable, The Princess and the Pea. To me, sometimes a pelvic exam is like the princess and the pea. It's when somebody's in pain. So to me, I get more information from the ultrasound than I can from my pelvic exam.
Okay.
No, really,
Guys?
ultrasound has been really interesting to watch. Both YouTube presentations as well as AEGL. A lot of great work on ultrasound out of Italy and Brazil. We can pick up a lot of the nodular disease in uterosacral ligaments, sometimes bowel invasion with wall thickening, nodular stuff in the low bowel. We can evaluate for ovarian adhesions, colon adhesions, small intestine adhesions to the uterus and the bladder. So after surgery, when there's concern about adhesions, like Dr. DeLemba brings it up, often ultrasound, if the ultrasonographer knows how to evaluate it and knows what they're looking for, we can look for signs of adhesions within that ultrasound management that can be very helpful.
Very good. Okay. Dr. Arrington, we're going to start with you on this one. B asks, I've heard this. If it reaches the lungs, it can be fatal. Is this true? Also, what kinds of endometriosis are there? Does race play a part in the type of endo a patient has? If the uterus can be transplanted, will a new uterus ever be given to an endo patient if she wants to conceive?
So I first off, if endometriosis reaches the lung, could it be fatal? Possibly, but not likely. A lot of that's going to depend on where the patient is, what medical community support they have. In the United States and developed nations, if it reaches the lung, usually they can cough up blood. They can I want to say drop a lung. I'm totally blanking on layman's terms.
Pneumothorax.
A pneumothorax is the medical term of it. Certainly that can be a medical emergency depending on how big a degree that hits, but most patients even though it can be very painful, most patients are going to be able to oxygenate well enough with a full functional lung on the other side. It is disease that likely needs to be treated and treated appropriately. Could it cause death? Yes. Will it cause death? Again, unlikely in developed nations. As far as does race play a role, honestly, I had to look up a little bit more specifics on this yesterday. There are some racial and ethnicity differences in occurrence of endometriosis or the rates of endometriosis, but from what I could tell, don't necessarily affect the aggressiveness or the numbers of patients that have deep disease versus superficial disease. And as we know, endo can be found all over different places in the body, but I don't know if ethnicity really plays a role in the likelihood of invasive endometriosis in other organs. And then I can't remember what the final question was.
If a patient, the uterus, if it can be transplanted, yes.
I can't see a reason why it wouldn't be. Again, that's going to be a whole ethical consideration. It's not something where we're dealing with patients with a cancer type situation. We're not dealing with patients who, say for liver transplant are alcoholics and that sort of thing. I could see very easily that it could be done. Again, it's going to be important to realize what are the accessibility of the blood vessels that you need to reconnect in order to do the reimplantation, with the distortion of the anatomy, the fibrosis, and all that stuff that can come not only from the disease itself, but from also management of the disease. Could it be done? Possibly. And I don't see endometriosis being a disease that would preclude a transplant.
All right. If
But
anyone,
I don't think we have that.
I mean, uterine transplant is like Star Trek right now. I mean, it's going on, but I mean, it's done under research protocols. It is nowhere near mainstream. It's been done a handful of times in the country. There are ethical concerns. I mean, the question is, why not transplant the fetus into a surrogate rather than transplanting the uterus into the person? But you know, we're decades away from uterine transplant being something that just somebody could just order up and do. I mean, it's a very, very cutting edge thing right now. Not that it's that complicated. I mean, it's just blood vessels and so forth. But although I've never done one, but we're aware of how it works. It's not that amazing, but you have to, you know, it is nothing. It is not something that you can just do.
Gotcha. Okay. All right, Dr. Dilembe, this one is for you. We'll start with you. Mo asks, I've been on the Mirena for the past 3 years and just came off of it 2 months ago due to the side effects. I'm concerned as lately I have been having terrible symptoms during the week of my ovulation, insomnia, moods, and painful chills. I am wondering, for those of us going through these issues, transitioning through hormonal treatment, if we should consider a reproductive endocrinologist for perimenopause symptoms. Any advice or test I should ask for?
Well, when it comes to this type of treatment, it's actually probably outside of my expertise. She doesn't give her age, so I don't know where she would be to consider herself perimenopausal. Going to a reproductive endocrinologist, most of them that I've dealt with don't really deal with this issue. Most of them want to do with the infertility aspect of it, but I'm sure there are some out there, and that would be a good place to start. Going through insomnia, ovulation, and mood swings and chills, that does seem to be related to the progesterone component, in my opinion. Certainly having been on the Mirena, she said for 3 years, and then came up for the last 2 months having these symptoms. Honestly, that's about the most I can give. Maybe the other experts can give more information on that than I can.
Libby, we haven't heard from you for a while.
Libby, you're up next, as a matter of fact.
I know.
If you don't have anything to add to this, we can jump into that.
Yeah,
Jeff,
let's do that.
Jeff, do you have any input on that? Because that's...
No. You know what, but there, I guess on the other side, there are plenty of general gynecologists, usually more of the more recent graduates that have had some training in what people call bioidentical. I call them, what do I call them? Compounded hormones. That some patients will find benefit with that. That's something you can look into, but I don't think necessarily requires a reproductive endocrinologist. And again, like Dr. DeLimba said, most of them are focusing on getting people pregnant.
Okay. All right, Libby. Melena O asks, I've heard having babies naturally helps get rid of the endo. Is that true? Does endo ever fully go away?
Well, starting with the question, does endo ever fully go away? I think that's probably already been kind of covered in a previous question. So, one of the myths about endometriosis that a lot of patients with endo will encounter at some point is, hey, having a baby would be a really great idea because, pregnancy is a great thing for endo, and ideally, if you could breastfeed the child until they're 20, that would be the best option for you. So I'll see you back in 3 months when you're pregnant, and we'll go from there.
And that's what they say to the 10-year-old.
Yeah. Mommy, what's pregnancy? So it's the first thing I will say is please don't have children in order to, in the hopes that try to get pregnant if you want a baby and want to have a family. Don't try to get pregnant because you think that it might cure your endo, because there's no evidence that pregnancy will cure endo. There's no evidence that pregnancy will make endo go away. Some women find their symptoms get worse during pregnancy. Some find that they don't. Some find that their symptoms get better. And there are lots of changes with your hormones going on during pregnancy. And that can help provide a period. Most women are not menstruating, well, not menstruating, but they're not bleeding during pregnancy. So, if they may find that they have less symptoms, but pregnancy itself is not really, some women don't have many symptoms with pregnancy, whereas others feel awful. So I wouldn't say you might be exchanging one issue with another issue and then you have a baby at the end. The other thing to consider is that, most patients will find that their symptoms, even if they have a period of time where their symptoms go away, their symptoms generally will return after pregnancy. And then you've got to deal with an infant, and you're still dealing with your endometriosis, and that's probably not a very easy situation to be in. So the idea of let's just get pregnant, that will fix it. The other thing is it's kind of insulting because besides the idea that hey, having a child's no big deal anyway. Besides that aspect, it's insulting because a lot of women have, they might want to have children, but they struggle to do so because of the endometriosis. It can cause infertility. So it's a sort of, it's wrong on every level, I think, when a doctor suggests that idea. Now, there was a study not that long ago where they followed up women, I think, for 20 years, a large group of women, and they looked to see of those who did become pregnant, for those who breastfed afterwards, they looked to see whether breastfeeding was at all protective against subsequently being diagnosed with endometriosis. So presumably these are women who did not previously have a diagnosis of endo, and they found that the longer women breastfed, the lower the risk of them being diagnosed with endo in the follow-up period. And it also seemed to be that if they exclusively breastfed, they were less likely to be diagnosed with endo. What I will say about that is that a diagnosis of endo is not quite the same thing as having endo, because obviously you can have endo, not be diagnosed. You're diagnosed usually when you have symptoms. So what it might suggest is that for whatever reason, breastfeeding might have, I'm not just talking about during the period of breastfeeding, but after the period of breastfeeding, whether that did sort of provide some longer term symptomatic buffer for some women, I don't know. But everyone's different. And if you do happen to get pregnant, then I guess you may be lucky to feel a lot better. And you may find that continues while breastfeeding, or you may not, but it's no guarantee.
Breastfeeding is a hypoestrogenic state. I mean, if you exclusively breastfeed, your estrogen levels will be low. And that is even shown in bone mineral density, that people that breastfeed exclusively for years will have notable changes in bone mineral density as well. And so much like low estrogen from looprun or low estrogen from a variety of things may improve endometriosis symptoms. Breastfeeding will lower estrogen as well, but again, it's not creating any long-term benefit. But while it's happening, I just recently had a patient that had endo when she had all the symptoms of endo when she was younger. Then she had 4 children, and now she's come off breastfeeding the last one for the better part of 3 years, which is quite common in the Pacific Northwest. And now she's having pain. And she says, well, I've never had endo before. I'm like, well, you've been pregnant or breastfeeding for the last 12 years. So, it makes sense.
And one other thing, I mean, there've been I've come across stories of a few patients who've said, I don't know if I had endo all along, but I didn't have problems until after I had my pregnancy. And so there are patients who only seem to become symptomatic after pregnancy, which I think is kind of interesting. It seems like anything in a woman's life that represents a change, a point of change in hormones, whether it be puberty, pregnancy, or perimenopause, can be associated with a change in symptoms, whether better or worse.
Okay, guys,
Nick, does that patient happen to be from Utah?
I don't think so.
Just pregnant breast for 12 years fits right in.
Well, is that one child or is that like 12 children?
Multiples.
Now.
You got to hit the stereotype sometimes.
I thought you're breastfeeding the other wives' children.
Someone needs to mute Nick.
How's it going for? Never mind.
Okay, guys, we only have a few minutes, actually 2 minutes left to be exact. We do have a handful of questions still left. I do want to try to get to one last question, and the remaining questions, if we'll have the doctors address the questions, Libby as well, and we will post them in Endotruthslive page. So if you did send in a question, it wasn't addressed, don't worry, we will get to it. So let's wrap it up with this one, and this one might take a couple of minutes, so feel free to elaborate as much as you want.
Or if we answered it, but we didn't address it, which is possible.
I didn't even notice. So yes, let's go ahead and try to get this one in. And like I said, it's an interesting one. So if you're not able to elaborate as much as you'd like to, Dr. Fogelson, then we could definitely put that in the page as well. Okay, so if this is from Jennifer, by the way, if endometriosis shares the same genetic mutations as cancer that causes it to spread throughout the body, why is it not classified as the type of cancer? Also, what exactly is endometriosis if it's classified as different from the endometrium on a molecular level? Also, I've read from medical journals where endometriosis has been fatal in some cases, mainly due to the lack of treatment of the illness. In these cases, it had spread to the liver, intestines, and lungs. Is this true? Dr. Fogelson.
Oh, okay. So is let's go last thing first. Can endometriosis be fatal? I mean, and you can't say never, but really, really unlikely. I mean, it would be extraordinarily unlikely to have someone die as a sequelae of endometriosis. Now,
can I add something in there too when you're done with that?
Sure. I mean, the worst thing that you could have would potentially be you could have a complete bowel obstruction, which could be fatal. I mean, if you had a true large bowel obstruction from endometriosis that was truly obstructing the bowel, but it's hard to imagine that would not lead to some kind of treatment. I mean, I think that by and large, endometriosis is not a fatal disease. Now, is it possible that in the history of time someone has died from endometriosis-related complications? It's certainly possible, but I don't think of it as a disease that is likely to lead to death in anyone, even in the absence of good treatment. Libby, you wanted to add?
Yeah, there's a publication on that actually about causes of death per illness, and you'd be amazed. People have died of crazy things. There probably about as many people have died of things like ingrown toenails, and it's pretty bad luck, or a dental abscess, as there have been. I mean, there are more women die of polycystic ovarian syndrome than they do from endometriosis. It's not a fatal condition. It's just if you neglect a condition, and you're very, very unlucky, then you can pretty much die of anything.
Can I add something in quick along those lines?
Sure, yeah, go ahead.
I think it's probably important, especially in today's world, that we do need to pull in that there are not women that very unrare or very unlikely that, well, a woman will die from endometriosis itself, but there are plenty that do die from management of endometriosis symptoms. When we look at chronic narcotic use, opioid dependency, that sort of thing.
Good point.
Suicide is always something that we worry about and comes up in these discussions and on the Facebook boards. And it's important for us to realize that those can also be sequelae of this disease that goes untreated and is so difficult for many, many patients.
No, I agree. It's important.
I agree too. That's a nice add.
You're asking about cancer versus endometriosis. So in my mind, and I think a reasonable diagnosis of what is a malignancy is two things. One is it has to be neoplastic, which means that you have a cell that has developed a genetic mutation that leads it to grow abnormally. Typically cells grow, and when they run up into other cells, they stop growing, whereas a cancer will grow over the top of other cells and kind of grow out of control. And so if you have to start out with abnormal cell growth, typically it's called monoclonal cell growth, which means that every cell in the cancer has the same mutations because they all started from one cell. The second thing they have to do is be able to invade other tissues, so that not only they develop the ability to grow out of control, but they have the ability to invade the tissue structures of other tissues. So we see tumors in the body that are neoplastic, such as a fibroid in the uterus is a neoplasm, but it is not a cancer because it doesn't have the ability to invade other tissues. Whereas if that same tissue invades, then we call it a sarcoma, and then it's a cancer. So endometriosis doesn't really fit either one of those things. It's not monoclonal. It's not a monoclonal neoplasm. You don't have like one cell that is just growing out of control. You have what appears to be the misplacement of endometrial cells from the inside of the uterus misplaced outside of the uterus, and we can argue about how they got there, but they don't really act like a neoplasm. And the invasion that endometriosis has into other tissue doesn't seem to be the endometriotic tissue invading as much as it is inflammation from probably the immune reaction to the endometriosis causing fibrosis, more than it is endometriotic tissue actually invading other tissues directly. And for that reason, I don't think endometriosis can really be classified as a neoplasm. But someone said, are the same genes involved? In some cases, the answer is yes. Some of the angiogenic genes, which are blood vessel genes that are involved in cancer, are also involved in endometriosis. But a lot of things in the body, most genes that go out of whack in cancer actually have a usefulness in the body somewhere. That's why they exist. It's not like a gene that is turned off and you don't have cancer and you turn it on and you have cancer. It's more like the gene does something useful, but then it gets disordered in the way it's being transcribed, and now it's behaving like a cancer. So it's hugely complicated, and I don't know all the answers, but I would, in short, endometriosis is not cancer, even though it behaves kind of like it.
Exactly. Okay.
Nick, real quick, any similarities between endometriosis and borderline ovarian tumors?
Not that I know of. So a borderline ovarian cancer is a non-invasive ovarian cancer. It looks just like ovarian cancer, but it doesn't. It metastasizes like ovarian cancer, but it doesn't invade other tissues. And there may be, Jeff, but I'm not aware of it.
Okay, y'all, I want to thank you again for your time. It has been wonderful having you guys here live on Facebook for Endotruthslive Q&A. I hope everyone enjoyed this, and hopefully we can do this again sometime soon. Everyone that's watching, thank you so much for tuning in. Make sure you tune in, or check out rather, Endotruthslive page. You're going to find information for each panelist on there, how to get in contact with them, how to follow them. If you have any follow-up questions, you can reach out to them directly if you choose to do so. And of course, this video will be viewable after we end the live broadcast. It will be posted in Endotruth's page as well. I will be uploading it to my YouTube channel as well. So everyone, yes, you definitely will be able to watch it after we end the live broadcast. But I am all set. If anybody else wants to add anything else, we are good to go.
Go Steelers.
Yes.
Brittany and Joy, thank you, and Libby, thank you always for all the work that you do with research and education. And
Yeah,
it
it's
was
really, without people like Libby and Brittany and Joy and everyone that, people talked about how doctors don't know about endometriosis well enough. I mean, the fact that there is so much more light being shown on endometriosis is not because of the doctors, it's because of people like Libby and people like Brittany and people, Nancy Peterson. And without those people, I don't think we would see this resurgence of knowledge and awareness. And I think you wouldn't see as many surgeons becoming interested in endometriosis either. So it's just a huge part of the progress towards taking better care of women.
Absolutely.
Great. Hey, thank you, guys. Dr. Fogelson, Dr. Arrington, it was great sharing information with you guys. And Libby, you're still as smart as ever. And thank you, thank you, Brittany. Thank you, Joy. Thanks, everybody.
Thanks, everyone.
Thank
Y'all
you,
have a great
everyone.
Monday.
Okay.
Bye.
Bye.
Bye-bye.
Bye.